Bowel cancer patients in Southland have suffered unacceptable delays, waiting months and even years to be diagnosed because of major failures at the Southern District Health Board. A damning independent report describes a state of inter-service warfare between bowel specialists in Dunedin and Southland hospitals, which it says means patients in Southland get a poorer service than those in Dunedin. By the time some patients got their colonoscopies to diagnose their cancers, they were already dying and could only be offered palliative care. The report's co-author, Christchurch surgeon Phil Bagshaw, spoke to our reporter Ruth Hill.
They've got one of the highest incidences of colorectal cancer. They've got the highest incidence of spread beyond the bowel at the time of diagnosis, the highest incidence of emergency surgery, and one of the lowest rates of colonoscopy. I mean, those facts in themselves mean that they have lost the battle in the war against bowel cancer, and that people should be taking responsibility for it. I think senior people in the DHB have known about that for a long time, and they just have not addressed those issues.
So what does the Southern DHB have to say about this? Well, I spoke to its Chief Medical Officer, Dr. Nigel Millar, and asked him to explain why the service at the DHB is so deficient.
We've encountered quite a lot of problems in Southern, and our process is to get through them all and resolve them. One of our principles is to be as open as possible, so people know what's going on. So therefore you hear, hopefully, quite easily and straightforwardly about the problems we're having.
Yes, now we appreciate you're upfront about that. The situation that, as we can see from the report, is that you've got one of the highest incidences of colorectal cancer, one of the highest rates of it spread beyond the bowel. I'm just reading off a list here, there's 2 to go. One of the highest rates of emergency surgery for that type of cancer, and one of the lowest colonoscopy rates. So the stats show that while you've got many cases of it, you've got one of the lowest, I think the second lowest colonoscopy rates in the country. I think maybe the third highest incidence of that type of cancer. It's not a good look.
Well, I don't think you can draw a conclusion that one causes the other. I quite agree. We've got work to do around our colonoscopy systems. However, I would say we do a large number of colonoscopies. Almost all, except for a small number we're looking into, compared to the several thousand we do, have met the targets and been within the government's guidelines and used the guideline system. And so that part of the system is performing relatively well. We recently started the screening program, one of the second or third DHB to do that, and that's running really well. We've got one of the highest uptake rates, 72%, and including a very similar or slightly higher rate for Maori, which is quite extraordinary achievement, and we're continuing to work on that. We take these sorts of things really seriously.
Yeah, but Dr. Millard, the first answer you gave was that you're going to be upfront about it, and the second answer is you seem to be gilding the lily about the real situation there. I mean, the study looked at 20 cases, 10 of which had unnecessary delays, and just like we've seen in the past with people who've had delays to urgent care, they've had in some cases, permanent damage. How does that make you feel about the service that you're running there?
Look, I can't feel anything but really uncomfortable and distressed to hear that patients could be harmed in our care. And I agree with you entirely about that. That's why we're determined to keep working on these things, to make sure we're as open as possible so people know what's happening. However, I will say again, there's a very small percentage, a minute part of our colonoscopy system that we're looking into. However, the reviewers unfortunately could only get through 20 cases, so therefore we're going to take this further and look right through a whole series more cases. And as well as that, not just looking at cases where concerns have been raised, looking at other cases to make sure things have been done properly. And where we find opportunities to improve, we certainly will. Okay.
At least the people that wrote the report seem to think that one of the causes here is staffing issues. They're talking about poor communication, dysfunctional relationships. The feedback to staff is through incident reports instead of direct communication. It doesn't sound like a wonderful place to work. We've also got serious staff disputes, and some staff say that this kind of thing impacts on the ability to recruit senior specialist staff, and also it's having an impact on patient care. What's the issue there amongst the staff?
Oh, well, I quite agree that where we have poor relationships between staff or strained relationships, that diminishes the effectiveness and puts our services at risk. And that's a really important thing for us. We do have a very active program about improving relationships. For this particular issue, we'll be calling on an expert to come in and spend some time working between the various groups to improve relationships. We've already spent time, and one of the recommendations from the report was to engage the surgeons directly in the assessment process for colonoscopy, so who needs colonoscopy. So they will now be directly engaged in that, and that's really encouraging. I'm looking forward to having their input in that so they can feel they're actually part of the system. The challenge for colonoscopy is to make sure we provide it for the right people. If we end up providing too many for the wrong people, we run back to where we were and where many places in the country were in the past, where there were large waiting lists. And that also causes quite considerable harm.
So what are you going to do? Because you said last year that you would put in place all the recommendations, and if not, you'd explain why. Some of the recommendations have made is one of them is to appoint this senior medical staff, who it sounds like from what you've just said you're going to do that. But also it talks about following the national guidelines so that people who are initially denied a endoscopy for bowel cancer, they'll be able to get a second opinion. They'll be able to actually have a follow-up if a specialist thinks it's worthwhile. Are you going to do that?
That's what we were saying. I was just saying. So the situation in Southland will be moved to where a colonoscopy is requested, and it's uncertain about whether it's the right thing. Then that goes to now two specialists, a gastroenterologist and a senior surgeon, to look at that between them and make a decision about whether that colonoscopy should be conducted or not. And one of those, of course, is a surgeon, to make sure they're part of the decision-making process around making sure we provide colonoscopy to the right people and the right times.
Another thing the reporters said was that it just took so long to get the information for this report, not just from your DHB. What's the issue there in terms of being able to get the information? Because you said you're going to look further into this and that 20 cases is just not enough. That sounds reasonable. If you want 100 cases, it's going to take forever and a day to get the data that you need.
First of all, the challenge for us is medical records these days are mixed. They're a mixture of written records, electronic, and unfortunately our reviewers didn't feel able to use the electronic section, which was challenging, and they weren't doing the reviews on site. So next time we'll do it on site. Those are the sort of challenges we have to get through, and we've designed a different system to get through the rest, which is where a senior nurse or a couple of senior nurses will go through the cases, screen out those that may cause concerns, and then they're looked at by the specialists. So we'll have a much streamlined system, and I'm sure that will work much better. And we'll focus just on the issue in hand. Clearly, the reviewers had other things they wanted to look at beyond that, around the national guidelines, the national systems, and I can understand their perspective on that. But we need to get through the focus on the actual cases.
Dr. Millar, you must be getting a little bit sick and tired of coming on Checkpoint and talking to us, because I've got a list here of interviews you've done with us. I won't go through all of them, but it goes back years where you've been very honest, brutally honest, saying we've got to wear this and we've got to improve. This survey found that there was a survey that was done in the report. 32.4%, I guess, of the doctors indicated, or maybe clinicians of some sort, indicated they were aware of patients they thought had come to harm as a result of having a referral for an endoscopy declined. What do you say to those patients?
Well, look, all I can say is that it's a tragedy when someone's harmed as a result of failings in our system, and I can't say anything, but we will be really sorry where that happens to people. It is important that we're honest and upfront. I came to Dunedin to make a difference, and that means paying a part, hopefully, in resolving some difficult and challenging problems.
Well, what's been resolved, though? I mean, the report writers say no one's taking responsibility here. Is it time that you took responsibility, or someone took responsibility?
Well, I don't think I have said I have not taken responsibility. I'm definitely responsible, absolutely, because I'm the chief medical officer, and that's my job. And my job is to help get through these things and get them resolved.
But can you understand why the public might be a little bit cynical about this? That because we're hearing the same thing over and over again. Is there a missing piece here that we need to fit into the puzzle? Well, is it funding? Is it someone who can get the job done?
Well, I hope I'm doing a reasonable job. If people don't believe I am, then I'm sure they'll find somebody else. Meanwhile, I'll keep on working to make a difference. The challenge with this is, that some of the things we've been open about, we had problems with ophthalmology, that will be on your list. Look, we found the problem in Southern. That is not a problem unique to Southern. But we wanted to be open about it and talk about it and make sure it got properly sorted and resolved. And so that's about the openness, and maybe that's harmful to us as an organisation, but in the long run, it's the right thing to do.
If this doesn't get resolved, and we have another incidence of this, where we've got a report saying people have come to harm because of these delays, are you going to offer your resignation?
Look, I would resign if I thought I couldn't make a difference. And I've been asked that now at least twice on your radio show. And it's not just my opinion on that. I don't personally hold sway on that. If other people think I'm not doing a good job, I'm sure I'll be given the indication.
Dr. Nigel Millar there, Chief Medical Officer of the Southern DHB.